Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine.
Hi, This Week in Medicine, we will be discussing. First, we will be discussing articles in New England Journal of Medicine. Beta blocker interruption or continuation after myocardial infarction. Background. The appropriate duration of treatment with beta blocker drugs after a myocardial infarction is unknown. Data are needed on the safety and efficacy of the interruption of long-term beta blocker treatment to reduce side effects and improve quality of life in patients with a history of uncomplicated myocardial infarction. Methods. In a multi-center, open-label, randomized, non-inferiority trial conducted at 49 sites in France, we randomly assigned patients with a history of myocardial infarction, in a 1-to-1 ratio, to interruption or continuation of beta blocker treatment. All the patients had a left ventricular ejection fraction of at least 40% while receiving long-term beta blocker treatment and had no history of a cardiovascular event in the previous 6 months. The primary endpoint was a composite of death, non-fatal myocardial infarction, non-fatal stroke, or hospitalization for cardiovascular reasons at the longest follow-up. Minimum, 1 year, according to an analysis of non-inferiority, defined as a between-group difference of less than 3 percentage points for the upper boundary of the two-sided 95% confidence interval. The main secondary endpoint was the change in quality of life as measured by the European Quality of Life 5 Dimensions Questionnaire results. A total of 3,698 patients underwent randomization, 1846 to the interruption group and 1852 to the continuation group. The median time between the last myocardial infarction and randomization was 2.9 years. Interquartile range, 1.2 to 6.4, and the median follow-up was 3.0 years. Interquartile range, 2.0 to 4.0. A primary outcome event occurred in 432 of 1812 patients, 23.8%, in the interruption group and in 384 of 1821 patients, 21.1%. In the continuation group, risk difference, 2.8 percentage points, 95% confidence interval, C, less than 0.1 to 5.5, for a hazard ratio of 1.16, 95% CI, 1.01 to 1.33, P equals 0.44 for non-inferiority. Beta blocker interruption did not seem to improve the patient's quality of life. Conclusions. In patients with a history of myocardial infarction, interruption of long-term beta blocker treatment was not found to be non-inferior to a strategy of beta blocker continuation. Hematologic cancer after gene therapy for cerebral adrenoleukodystrophy. Background. Gene therapy with a livaldigene autotemsil, ELI cell, consisting of autologous CD34 plus cells transduced with lentiviral vector containing ABCD1 complementary DNA, Lenti-D, has shown efficacy in clinical studies for the treatment of cerebral adrenoleukodystrophy. However, the risk of oncogenesis with ELI cell is unclear. Conclusions. Hematologic cancer developed in a subgroup of patients who were treated with ELI cell. The cases are associated with clonal vector insertions within oncogenes and clonal evolution with acquisition of somatic genetic defects. Lentiviral gene therapy for cerebral adrenoleukodystrophy. Background. Cerebral adrenoleukodystrophy is a severe form of X-linked adrenoleukodystrophy characterized by white matter disease, loss of neurologic function, and early death. A livaldigene autotemsil, ELI cell, gene therapy, which consists of autologous CD34 plus cells transduced with Lenti-D lentiviral vector containing ABCD1 complementary DNA, is being tested in persons with cerebral adrenoleukodystrophy. Conclusions. At a median follow-up of 6 years after lentiviral gene therapy, Most patients with early cerebral adrenoleukodystrophy and MRI abnormalities had no major functional disabilities. However, insertional oncogenesis is an ongoing risk associated with the integration of viral vectors. Durvalumab after chemoradiotherapy and limited-stage small cell lung cancer. Background: adjuvant therapy with Durvalumab, with or without tremelimumab, may have efficacy in patients with limited-stage small cell lung cancer who do not have disease progression after standard concurrent platinum-based chemoradiotherapy results. A total of 264 patients were assigned to the Durvalumab group, 200 to the Durvalumab tremelimumab group, and 266 to the placebo group. Durvalumab therapy led to significantly longer overall survival than placebo, median, 55.9 months, 95% confidence interval, CI, 37.3 to not reached, versus 33.4 months, 95% CI, 25.5 to 39.9, hazard ratio for death, 0.73, 98.321% CI, 0.54 to 0.98, p equals 0.01, as well as to significantly longer progression-free survival, median 16.6 months, 95% CI, 10.2 to 28.2, versus 9.2 months, 95% CI, 7.4 to 12.9, hazard ratio for progression or death, 0.76, 97.195% CI, 0.59 to 0.98, p equals 0.02. The incidence of adverse events with a maximum grade of 3 or 4 was 24.4% among patients receiving Durvalumab, and 24.2% among patients receiving placebo. Adverse events led to discontinuation in 16.4% and 10.6% of the patients, respectively, and led to death in 2.7% and 1.9%. Pneumonitis or radiation pneumonitis with a maximum grade of 3 or 4 occurred in 3.1% of the patients in the Durvalumab group and in 2.6% of those in the placebo group. Conclusions: adjuvant therapy with Durvalumab led to significantly longer overall survival and progression-free survival than placebo among patients with limited-stage small cell lung cancer. Next, we will be discussing articles from Journal of American Medical Association Restrictive versus Liberal Transfusion Strategy in Patients with Acute Brain Injury, the TRAIN Randomized Clinical Trial. Question: how does use of a liberal or restrictive strategy of blood transfusion influence neurological outcome among patients with acute brain injury? Findings: in this randomized clinical trial that included 850 patients with acute brain injury and a hemoglobin level below 9 grams/dl, those who were treated with a liberal transfusion strategy triggered by hemoglobin below 9 grams/dl had a lower probability of unfavorable neurological outcome at 180 days than those treated with a restrictive strategy triggered by hemoglobin below 7 grams/dl, 62.6% versus 72.6%, respectively. Adjusted relative risk, 0.86, meaning a liberal transfusion strategy compared with a restrictive strategy resulted in a lower rate of unfavorable neurological outcome among patients with acute brain injury. Extracorporeal blood purification and acute kidney injury in cardiac surgery, the A.I.O. randomized clinical trial. Question: does the use of a non-selective extracorporeal blood purification (EBP) device connected to the cardiopulmonary bypass circuit reduce the incidence of acute kidney injury (AKI) in high-risk patients undergoing cardiothoracic surgery? Findings: in this randomized clinical trial that included 343 adults, a significant decrease in cardiac surgery-associated AKI was observed in those treated with EBP compared with those who were not, 28.4% versus 39.7%, meaning, in high-risk patients undergoing cardiac surgery, the use of a non-selective EBP device was associated with a significant reduction in AKI in the first 7 days after surgery. Next, we will be discussing articles from Annals of Internal Medicine. Pain reduction with oral methotrexate in knee osteoarthritis. Background. Treatments for osteoarthritis, OA, are limited. Previous small studies suggest that the anti-rheumatic drug methotrexate may be a potential treatment for OA pain. Results. A total of 155 participants, 64% women, mean age, 60.9 years, 50% Kellgren-Lawrence grade 3 to 4, were randomly assigned to methotrexate, N equals 77, or placebo, N equals 78. Follow-up was 86%, N equals 134, methotrexate, 66, placebo, 68, at 6 months. Mean knee pain decreased from 6.4, SD, 1.80, at baseline to 5.1, SD, 2.32, at 6 months in the methotrexate group and from 6.8, SD, 1.62, to 6.2, 6.2, SD, 2.30, in the placebo group. The primary intention to treat analysis showed a statistically significant pain reduction of 0.79 NRS points in favor of methotrexate, 95% CI, 0.08 to 1.51, p equals 0.030. There were also statistically significant treatment group differences in favor of methotrexate at 6 months for Western Ontario and McMaster University's Osteoarthritis Index Stiffness, 0.60 points, CI, 0.01 to 1.18, p equals 0.045, and function, 5.01 points, CI, 1.29 to 8.74, p equals 0.008. Treatment adherence analysis supported a dose-response effect. 4 unrelated serious AEs were reported. Methotrexate, 2, placebo, 2. Conclusion. Oral methotrexate added to usual medications demonstrated statistically significant reduction in KOA pain, stiffness, and function at 6 months. Next, we will be discussing articles from British Medical Journal. Rainfall events and daily mortality across 645 global locations. Objective: to examine the associations between characteristics of daily rainfall, intensity, duration, and frequency, and all-cause, cardiovascular, and respiratory mortality. Results during the study period. A total of 5,913 rainfall events with a 1-year return period, 8,362 events with a 2-year return period, and 3,301 events with a 5-year return period were identified. A day of extreme rainfall with a 5-year return period was significantly associated with increased daily all-cause, cardiovascular, and respiratory mortality, with cumulative relative risks across 0 to 14 lag days of 1.08, 95% confidence interval 1.05 to 1.11, 1.05, 1.02 to 1.08, and 1.29, 1.19 to 1.39, respectively. Rainfall events with a 2-year return period were associated with respiratory mortality only, whereas no significant associations were found for events with a 1-year return period. Nonlinear analysis revealed protective effects, relative risk less than 1, with moderate heavy rainfall events, shifting to adverse effects, relative risk greater than 1, with extreme intensities. Additionally, mortality risks from extreme rainfall events appeared to be modified by climate type, baseline variability in rainfall, and vegetation coverage, whereas the moderating effects of population density and income level were not significant. Locations with lower variability of baseline rainfall or scarce vegetation coverage showed higher risks. Conclusion: daily rainfall intensity is associated with varying health effects, with extreme events linked to an increasing relative risk for all-cause, cardiovascular, and respiratory mortality. The observed associations varied with local climate and urban infrastructure. Next, we will be discussing articles from Lancet. Tivozanib plus nivolumab versus Tivozanib monotherapy in patients with renal cell carcinoma following an immune checkpoint inhibitor. Results of the Phase 3 TiNivo-2 study. Background. Immune checkpoint inhibitors, ECs, and vascular endothelial growth factor receptor tyrosine kinase inhibitors are cornerstones of first-line treatment for advanced renal cell carcinoma, However, optimal treatment sequencing after progression is unknown. This study aimed to assess clinical outcomes of Tivozanib nivolumab versus Tivozanib monotherapy in patients with metastatic renal cell carcinoma who have progressed following 1 or 2 lines of therapy in the post-IC setting. Findings. From November 4, 2021 to June 16, 2023, 343 patients were randomly assigned to Tivozanib nivolumab, N equals 171, or Tivozanib monotherapy, N equals 172. Median follow-up was 12.0 months. Median PFS was 5.7 months. 95% CI 4.0 to 7.4, with Tivozanib nivolumab and 7.4 months, 5.6 to 9.2, with Tivozanib monotherapy, hazard ratio 1.10, 95% CI 0.84 to 1.43, P equals 0.49. Among those with an ICI as their immediate previous therapy, N equals 244. Median PFS was 7.4 months, 95% CI 5.6 to 9.6, with Tivozanib nivolumab and 9.2 months, 7.4 to 10.0, with Tivozanib monotherapy. With non-ECs as the most recent therapy, lower median PFS was observed, with no difference between groups. Tivozanib nivolumab 3.7 months, 95% CI 2.7 to 5.4, and with Tivozanib monotherapy 3.7 months, 1.9 to 7.2. Serious adverse events occurred in 32% of 168 patients receiving Tivozanib nivolumab and 37% of 171 patients receiving Tivozanib monotherapy. 1. Less than 1% treatment-related death occurred. Tivozanib group. Interpretation. These data further support that ICI rechallenge should be discouraged in patients with advanced renal cell carcinoma. Furthermore, these data suggest that Tivozanib monotherapy has efficacy in the post-IC setting. Effects of oral sepiapterin on blood Phe concentration in a broad range of patients with phenylketonuria, affinity, results of an international, Phase 3, randomized, double-blind, placebo-controlled trial. Background. Phenylketonuria is an inherited condition characterized by neurotoxic accumulation of phenylalanine Phe. Affinity assessed the efficacy and safety of orally administered synthetic sepiapterin in children and adults with phenylketonuria. Interpretation. Sepiapterin is a promising oral therapy for individuals with phenylketonuria, was well tolerated, and resulted in significant and clinically meaningful reductions in blood Phe concentration in participants with varying disease severity. Next, we will be discussing articles in the field of hemato-oncology. Here are the articles from Journal of Clinical Oncology. Post-transplant plans. Cyclophosphamide-based graft versus host disease prophylaxis attenuates disparity in outcomes between use of matched or mismatched unrelated donors. Purpose. Access to allogeneic hematopoietic cell transplantation, HCT, remains limited among persons of non-European ancestry if human leukocyte antigen, HLA, matching is required. We evaluated whether post-transplant cyclophosphamide, C-based graft versus host disease, GVHD, prophylaxis improved HCT outcomes with HLA-matched unrelated donor, MUD, and mismatched unrelated donor, MMUD, HCT when compared with calcineurin inhibitor, CNI-based prophylaxis. Use of C results in comparable OS and GRFS using either MUD or MO-HCT, expanding access to HCT for patients from all racial and ethnic ancestry groups. Next, we will be discussing articles in the field of gastroenterology. Here are the articles from Gastroenterology. WNT oncogenic transcription requires mixed suppression of lysosomal activity and EpCAM stabilization in gastric tumors. Background and aims. WNT signaling is central to spatial tissue arrangement and regulating stem cell activity, and it represents the hallmark of gastrointestinal cancers. Although its role in driving intestinal tumors is well characterized, WNT's role in gastric tumorigenesis remains elusive. Our results uncovered a new signaling framework with important implications for the control of gastric epithelial architecture and WNT-dependent oncogenic transformation. Organoids for functional precision medicine in advanced pancreatic cancer. Background and aims. Patient-derived organoids, PDOs, are promising tumor avatars that could enable ex vivo drug tests to personalize patients' treatments in the frame of functional precision oncology. However, clinical evidence remains scarce. This study aims to evaluate whether PDOs can be implemented in clinical practice to benefit patients with advanced refractory pancreatic ductal adenocarcinoma, PDAC. Conclusions. We report the largest prospective study aiming at implementing PDO-based functional precision oncology and identify very robust predictive values in this clinical setting. In a clinically relevant turnaround time, we identify putative hits for 91% of patients, providing unexpected potential survival benefits in this very aggressive indication. Although this remains to be confirmed in interventional precision oncology trials, PDO collection already provides powerful opportunities for drugs and combinatorial treatment development. Next, we will be discussing articles in the field of rheumatology. Here are the articles from Journal of Clinical Rheumatology. Factors associated with successful withdrawal of biologic agents in children with colchicine-resistant familial Mediterranean fever. Background. Familial Mediterranean fever, FMF, is a monogenic autoinflammatory disease, and colchicine is the mainstay of treatment. Approximately 5% to 10% of patients may respond inadequately to colchicine, and anti-interleukin-1, anti-IL-1, agents are important treatment options in these patients. The aim of this study was to see whether there is any factor associated with the withdrawal of these anti-IL-1 agents and to investigate the characteristics of colchicine-resistant FMF patients who needed biological therapy. Conclusions. Low ISSF scores before biological treatment with no accompanying exertional leg pain. Subclinical inflammation and comorbidities may be stated as an associated factors in terms of the discontinuation of biological agents in colchicine-resistant pediatric FMF patients. Next, we will be discussing articles in the field of cardiology. Here are the articles from Circulation. Relationship of subendocardial perfusion to myocardial injury, cardiac structure, and clinical outcomes among patients with hypertension. Background. Coronary microvascular dysfunction has been implicated in the development of hypertensive heart disease and heart failure, with subendocardial ischemia identified as a driver of sustained myocardial injury and fibrosis. We aimed to evaluate the relationships of subendocardial perfusion with cardiac injury, structure, and a composite of major adverse cardiac and cerebrovascular events consisting of death, heart failure hospitalization, myocardial infarction, and stroke. Conclusions. Among patients with hypertension without flow-limiting coronary artery disease, impaired MF subendo was associated with cardiovascular risk factors, elevated cardiac biomarkers, cardiac structure, and clinical events. Here are the articles from Journals of the American College of Cardiology. Minimum national prevalence of diagnosed atrial fibrillation inferred from California acute care facilities. Background. Prevalence estimates of atrial fibrillation, AF, from large populations have not been updated for greater than 2 decades. Using data from 1996 to 1997, a previous study projected that there would be 3.3 million adults with AF in the United States in 2020. One objectives. The purpose of this study was to determine the contemporary age, sex, and race standardized prevalence and the number of adults with diagnosed AF in the United States. Conclusions. The prevalence of diagnosed AF in the United States is higher than previously estimated. More efficient prevention and treatment strategies are needed to curb the burden of AF in the United States. Next, we will be discussing articles in the field of endocrinology. Here are the articles from Diabetes Care. Hemoglobin A1C genetics and disparities in risk of diabetic retinopathy in individuals of genetically inferred African American/African British and European ancestries. Objective: individuals with diabetes who carry genetic variants that lower hemoglobin A1C, HeBO1C, independently of glycemia, may have higher real, but undetected, hyperglycemia compared with those without these variants despite achieving similar HeBA1C targets, potentially placing them at greater risk for diabetes-related complications. We sought to determine whether these genetic variants, aggregated in a polygenic score, and the large effect African ancestry-specific missense variant in G6PD, RS1050828, that lower HeBA1C were associated with higher retinopathy risk. See inclusions. Genetic effects need to be considered to personalize HeBA1C targets and improve outcomes of people with diabetes from diverse ancestries. Comprehensive multiple risk factor control in type 2 diabetes to mitigate heart failure risk. Insights from a prospective cohort study. Objective: the impact of comprehensive risk factor control on heart failure, HF, risk and HF-free survival time in individuals with type 2 diabetes, T2D, was evaluated in this study. Comprehensive management of risk factors is inversely associated with HF risk, and optimal risk factor control may prolong HF-free survival time among individuals with T2D. Next, we will be discussing articles in the field of pulmonary and critical care. Here are the articles from the American Journal of Respiratory and Critical Care Medicine. Exploring definitions and predictors of severe asthma clinical remission after biologic treatment in adults. Rationale: there is no consensus on criteria to include in an asthma remission definition in real life. Factors associated with achieving remission after biologic initiation remain poorly understood. Objectives: 2. Quantify the proportion of adults with severe asthma achieving multi-domain defined remission after biologic initiation and identify pre-biologic characteristics associated with achieving remission that may be used to predict it. Conclusions: 1 in 5 patients achieved 4-domain remission within 1 year of biologic initiation. Patients with less severe impairment and shorter asthma duration at initiation had a greater chance of achieving remission after biologic treatment, indicating that biologic treatment should not be delayed if remission is the goal. Next, we will be discussing articles in the field of nephrology. Here are the articles from Kidney International Reports. Clinical outcomes of a novel multidisciplinary care program in advanced kidney disease, PEAK Introduction. Multidisciplinary care, MDC, for late-stage chronic kidney disease, CKD, has been associated with improved patient outcomes compared with traditional nephrology care. However, the optimal MDC model is unknown. In 2015, we implemented a novel MDC model for patients with late-stage CKD informed by the Chronic Care Model conceptual framework, including an expanded MDC team, care plan meetings, clinical risk prediction, and a patient dashboard. Results. Among 489 patients in the PEAK program, 37.8%, died prior to ESKD and 151, 31%, never progressed to ESKD. Of the 301 patients, 62%, who progressed to ESKD, 175, 58%, achieved an optimal transition to ESKD, including 54, 18%, on peritoneal dialysis, 16, 5%, on home hemodialysis, and 36, 12%, to preemptive transplant. Of the 195 patients, 65%, starting ICHD, 51% started with an AVF or average and 52% started as an outpatient. The likelihood of starting home dialysis increased by 1.34 times per year from 2015 to 2020. 95% confidence interval, CI, 1.05 to 1.71. P equals 0.018 in multivariable adjusted results. Optimal transitions to ESKD and home dialysis rates were higher than the national USARDS data, 58% versus 30%, 23% versus 11%, across patient race, ethnicity, and payer. Conclusion. Patients enrolled in a novel comprehensive MDC model coupled with risk prediction and health information technology were nearly twice as likely to achieve an optimal transition to ESKD and start dialysis at home, compared with national averages. Bringing a systems approach to living donor kidney transplantation. Introduction. Living donor kidney transplantation, LDKT, is the best treatment option for patients with kidney failure. Efforts to increase LDKT have focused on micro-level interventions, and the need for systems thinking has been highlighted. We aimed to identify and compare health system-level attributes and processes that are facilitators and barriers to LDKT results. Our findings showed a strong relationship between the degree of centralized coordination between governing organizations and the capacity to deliver LDKT as follows. Macro-level coordination between governing organizations in British Columbia and Ontario increased capacities, whereas Quebec was seen as decentralized with little formal coordination. 2. A higher degree of centralized coordination facilitated more effective resource deployment in the form of human resources and initiatives in British Columbia and Ontario, whereas in Quebec resource deployment relied on hospital budgets, leading to competition for resources and reduced capacity of initiatives. 3. Informal resource sharing through strong communities of practice and local champions facilitated LDKT in Ontario and British Columbia and was limited in Quebec. Conclusion. Our findings suggest that interventions that account for full system function, particularly macro-level coordination between governing organizations, can improve LDKT delivery. Findings may be used to guide structured organizational change toward increasing LDKT and mitigating the global burden of kidney failure.
Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.